Another question from Facebook. What changes are in place for labor and delivery? How many people can be there with the patient?
We haven't made any changes in labor and delivery since, well, we made one change. I'll get to that, but nothing major. Since we put our visiting restrictions in place, labor and delivery was, from the very beginning, one of the exception areas that allowed a laboring mother to have one person with her, a husband, a mother, or whomever the patient chose, but only one through the laboring process. The one change that we made as this evolved was, initially we said that visitor or that support person was welcome in the labor and delivery suite, but if a case converted to a cesarean section and required a move to the OR, that the person was not allowed to go into the operating room. After getting some feedback from the community, we did modify that so that that support person can go into the operating room now, even for a C-section or another kind of operative delivery, with the staff, the physicians obviously having the right to ask them to leave if there's a reason to escalate things in the operating room. But that's the one change we made. Otherwise, there hasn't been any. And honestly, as we think about the opening of the community, the addition of some elective procedures in the days ahead, we think that our visiting restrictions are going to be among the last things that we change. So I don't anticipate opening the hospital to visitation beyond the current restrictions anytime soon, even if we begin to do elective procedures and other work.
A question from Caitlin at the MRT. Can you speak about the need for plasma donations and what the qualifications are to donate?
I'll struggle with the qualifications, so I'm going to ask Dr. Wilson to come back and talk about that a little bit. There is an interest in that. You want to come up, Larry? There certainly is an interest in getting plasma donations from patients who have, see, that's a fairly small population in our community.
So the currently for plasma donation, or really what we're looking at is convalescent serum donation. Plasma we all have, but the patients that have recovered from a COVID infection presumably are carrying antibodies to protect against the infection, and we passively can give those to another person to protect they might experience. So the idea is that we first of all have to identify a person who's been positive for COVID. So they have to have a positive COVID test. Then they have to go through the illness, recover with a negative COVID test, and then a 14-day window from recovery to the time that they harvest the serum. And the purpose of that is to make sure that they are clear of the infection. We accomplish that, we capture these people that are in that circumstance, then we can use their plasma and they can donate the plasma weekly. And we can collect plasma for a period of time for a variety of different other patients that, again, test positive for COVID and are showing signs that they're deteriorating with the infection, and we can provide them the antibodies to help protect against it.
Don't go far, Larry. I think we may need you again. Tessa?
Another question from Facebook.
Okay.
If you all decide to open the hospital to more people and elective surgeries, what safeguards will you take to safeguard the community spread?
That's a very good question, and many that we have talked incessantly about since we began to talk about the possibility of reopening. So there are several elements of this plan to be evolving and actually going up and down potentially as the hospital's activity continues. We have, as you know, deferred essentially all elective procedures for several weeks now. Surgeons and GI docs, cardiologists recognize that patients need these services. They're, as we've talked about a couple of times, the definition of elective is not unnecessary. It really refers to how urgent. We like to think we don't do unnecessary procedures, but those that don't involve the potential loss of life or limb or chronic pain that has to be managed can be deferred. We can wait a while. That's what we've been doing. But as we get weeks and weeks into this, it's harder and harder for those patients to wait. So as we think about returning to doing that kind of work, we've talked about a team, a surgery department leader, an anesthesia leader, administrative and nursing staff folks all together assessing the schedule times a week and comparing that schedule against the likelihood of needing an inpatient bed, our availability of personal adequate not only to care for the surgery patients, but for the COVID patients and others who are isolated in the hospital. And we anticipate that we'll be telling our surgeons and our patients that they should expect that there could be adjustments in the schedule from day to day as we make those assessments and determine how much we can handle in terms of volume. We will be particularly careful about patients that we know to need inpatient care, need critical care post-operatively, patients who will need blood. Blood supply is challenged right now as blood donation has been curtailed a bit during the stay-at-home orders. So we've got a wide variety of things we'll be doing. As you think about visitation and those kinds of things, we don't expect to be opening visitation rules any more than they are now. But if you've ever had an outpatient surgery, you know that we always ask you to bring someone with you. Having been sedated, having some medication still on board, so every patient has to have someone with them to go home after surgery. How to manage that, but it's probably going to involve staying in your car and being available by cell phone and calling the family member to come and get the patient when their care is. Those are the kinds of things that we're going to have to navigate. Makes life a little bit more difficult for sure, but we do expect to be able to get patients, especially those with the most, into the operating room, into the GI lab, into the cath lab in the days to come to make sure we provide the care that our folks need.
Okay, we have a question from Mitch. Can you give us more details about how the outbreak began at Midland Medical Lodge? Exposure to a known as listed. Was the original source of the virus a staff member or a visitor?
This is sort of a health department inquiry, really. We know a little bit about that, but I don't think any of us pretend to step into the health department's shoes. We're not doing contact tracing and the kind that is their responsibility, and so I think we'll refrain from trying to answer that question, Mitch, and I would encourage you to address that to the health department.
Mitch, could you clarify on your next question if that's a timeline of the outbreak at Midland Medical Lodge or a time of the outbreak for COVID in our community? And I'll wait for your response and I'll move on to the next question while we get that clarification. From Caitlin at the MRT, have you treated any patients with plasma so far?
I believe there's been one, right? We've treated just one so far.
We have clarification from Mitch. It's a timeline for the Midland Medical Lodge, which he believes you've already addressed. We have a question from Facebook. I've heard pharmacists now have tests. Are they in Midland pharmacies now? And then a second follow-up question I'll ask after.
I think there's been publicity about one of the national pharmacies, and do you remember which one it is? I won't say which. Stay with. See, okay, Dr. Wilson says it's CVS. So CVS has had some publicity about opening testing centers in certain locations. As far as we know, there is no plan to do that in Midland. I read, a lot of news feeds, and I know that in the Houston area there were 2 of them that were planning to be opened within the next few days, but there were a relatively limited number of them spread around the country, and Midland is not one of the locations that's planned as of now.
Okay, we have another question from Facebook. Does our hospital comply with the capacity requirements issued yesterday?
I would ask you to clarify the question. I'm not sure what that refers to.
Okay. We'll watch for that clarification.
Okay.
And then we have another question on Facebook regarding the patient that plasma was used on. And did we have a positive result with that?
I'll ask Dr. Wilson to address that one.
Start off with a cautionary comment that there's a N of 1. You know, we've had one patient that's been treated with this, and if that patient may have very well, we've had many patients that have come through, looked very, very sick, and then rebounded and recovered very, very effectively without using the serum, the convalescent serum. But in this particular case, the patient received the convalescent serum and within about 36 hours was improving quite dramatically, and was able to be taken off the ventilator within the last 24 hours or so, and is currently being moved, or soon will be moved, off of the critical care unit to the medical floor with an anticipation of a good recovery. So we're very fortunate and happy for the patient and for the outcome.
That's the challenge with all of the therapies that get a lot of public discussion. None of them have really a comprehensive scientific basis to them, and it's tempting to credit recoveries to the serum plasma use, or even to the other drug regimens, when we really don't know for sure that that's what caused the recovery. We've had many patients who have fully recovered without any drug regimen to speak of. So that's explains some of the caution you'll hear from Dr. Wilson and others, that while we're hopeful that these things work, we can't be certain that that's what's operating in the patient's recovery.
It looks like that's all the questions we have this morning.
Okay, thank you all for your time and attention, and we will see you again Monday morning.